So I was tasked in the context of integrating available therapies into primary care in the context of management of persons with fatty liver disease. My background is in hepatology, very involved in clinical trials, like I said, but I think the other aspect is really the context of screening linkage to care and importantly, trying to integrate all different aspects of therapy into the patient. These are my disclosures, mostly in the context of clinical trials. The objectives today are really to discuss the role of incretins and upcoming MASH therapies, review agents in the context of type 2 diabetes as well as obesity, and understand the potential role of bariatric surgery. There are a number of therapeutic trials and a number of therapeutic targets to consider. I'm trying to include this both from an intrahepatic perspective as well as a extrahepatic perspective. And when we look into the liver, it's essentially in that green box that you see, and these are different agents which are in clinical trials for persons with fatty liver disease. And then if you look outside the liver, it's mostly in the context of incretin therapies to try and affect insulin resistance. Let's look first into the liver. So this is a liver-targeted thyroid receptor beta selective agonist, which is known to affect fatty acid oxidation. And resmetirom is approved and utilized in the United States since March 2024, though is not available in Canada. I include this because a number of patients who I see will ask about resmetirom, when we are getting it, if we'll get it, or if they can just simply go down south and pick up some resmetirom and they can use it. This is the data set for it. This is the primary endpoints at week 52, looking at NASH resolution or improvement of one stage of fibrosis. And both these aspects are important. It's important that this is for patients with stage 2 or stage 3 fibrosis. First, we'll look at NASH resolution on the y-axis, percentage of responders, on the x-axis, placebo at 10%, and the resmetirom doses you see at 26 to 30% responders. More importantly, we look and try and search for improvement of stage of fibrosis. So this is greater than one stage of fibrosis after 52 weeks of therapy. Again, the placebo group at 14% and the two doses of resmetirom at 24 and 26%. So you may say, look, this is only a 12 or 14% change in the context of improvement of stage of fibrosis, but certainly this is statistical significance, it's clinically significant, and a number of patients have been treated in the US, and we now see this in Europe. I'm not sure if or when this will be seen in Canada. Let's move down to going into the incretin therapies. These are thought to affect or treat or moderate hepatic steatosis extrahepatically and effects on insulin resistance. I'm first going to mention the phase 3 data set, which is of semaglutide at 2.4 milligrams weekly, which is the obesity dose. This is done in patients with stage 2 and stage 3 fibrosis, and we can see an escalating dose weekly compared to placebo. If we look at baseline characteristics in persons treated with semaglutide or placebo, we see similar context of 55% who have type 2 diabetes, BMI mean of 34, and when we look at stage of fibrosis, about 68-69% of stage of fibrosis. So essentially, if we look at the patient population, I think it clearly reflects what we see in clinical practice, patients who have type 2 diabetes and a higher BMI. And it's good to see this data set, in particularly in patients with stage 3 fibrosis. So what is the bottom line data? This is only for patients with stage 2, stage 3 fibrosis. This is the week 72 data. First is the resolution of MASH with no improvement or no worsening of liver fibrosis, Y-axis, number of persons responding, and on the x-axis, semaglutide at 62.9% versus placebo at 34%. And then when you look at the context of semaglutide with improvement of one stage of fibrosis, you see this at 37% versus placebo. So again, we do see that semaglutide treated in persons up to 72 weeks, that we do get this improvement of fibrosis regression, which is clearly an important feature which you're looking at. Certainly, we expect the MASH resolution from the phase 2 data set when we're happy to see the improvement of fibrosis. As expected in persons with semaglutide, we do see side effects which are often GI related, And again, the context of how you dose the patient is really important with slow dose escalation, as we've understood, and really being involving the patient in the context of the management and particularly side effects of this therapy. I'm now going to show you data sets from the dual agonist. So this is tirzepatide. This is phase 2 data set. Again, looking at stage 2 and stage 3 fibrosis at 52 weeks. As per previously, I always put resolution of MASH and no worsening of fibrosis first, percentage of participants on the y-axis that actually get to this endpoint. And you can see the different doses of tirzepatide with a high dose at 15 milligrams, and 62% have improvement or resolution of MASH with no worsening of fibrosis versus 10% in the placebo. And when you look at improvement of fibrosis of greater than one stage and no worsening of MASH at the different doses, here about 51% versus placebo by 30%. So you can see that the context of the incretins have improved fibrosis overall. This is going to phase 3 data set. We already have good phase 3 data from semaglutide, which has been approved in the United States and is on label there. In Canada, we're waiting for Health Canada approval, and then we shall see how reimbursement will help us with trying to obtain this for our patients. It's important also to consider with incretin-based therapies, this is not only about MASH, right? This is about treating and considering the patient as a whole because, and I'm just showing you one data set, but there are numerous data sets you're already aware of in patients with type 2 diabetes as well as obesity, looking at cardiovascular outcomes, renal outcomes. And this is the SELECT study using semaglutide at 2.4 milligrams, similar to what we've seen in MASH, and looking at overall incidence of MACE and the improvement of this. On the y-axis, the cumulative incidence, and on the x-axis, the number of months since randomization. And semaglutide is in the bluer arm, and placebo is in the gray arm. And you see the significant improvement in persons going on to develop these major adverse cardiovascular outcomes. So overall, considering this, there is improvement in patients beyond that just MASH if you were even not to consider that. I'm going to shift again back into considering future therapies. I put the first two therapies essentially as either approved in the United States and or in Canada, waiting for Health Canada. But this is where we're going to look forward into the hopefully next couple of years. These are fibroblast growth factors, FGF analogs, which work intrahepatically to decrease fatty acid oxidation, as well as the context of anti-inflammatory, and that's thought indirectly to decrease fibrosis. So these are supposed to be true antifibrotic agents. There are a couple of them which I talked about. First is efruxifermin, which is a once-weekly therapy, and we look at the reduction of fibrosis. And specifically, I chose this because this is improvement in patients with cirrhosis. So this is the first data sets we're actually glimpsing of improvement in cirrhotic patient to reduce the fibrosis, and this shows data at 96 weeks. Number of or percentage of patients on the y-axis, placebo at 11%, improving by one stage of fibrosis. And if you look at the higher dose of this agent once weekly, we see 29% have greater than 1% improvement of one stage improvement in fibrosis in a cirrhotic patient, which gives us a lot of optimism. There are now glimpses of data to actually show improvement in portal hypertension with this agent as well. This is a once monthly FGF21 analog as well, which is now in phase 3 data. I'm showing you the phase 2 data set at just 24 weeks of therapy. I'm going to show you the red box looking at fibrosis improvement by greater than one stage without worsening of MASH. Placebo at 21% versus the active agent at 45%. Again, really good data, and this is just at 24 weeks of therapy. So very much looking forward to see these therapies in phase 3 and thereafter, hopefully in clinical practice to improve the context of fibrosis, even in patients with advanced disease. Bariatric surgery, there are numerous studies in bariatric surgery. I think this exemplifies this well. This is in patients who underwent bariatric surgery for obesity, and they're looking at fibrosis stage in patients. I'll show you fibrosis stage before bariatric surgery, then at year 1 and year 5 after bariatric surgery. patients with minimal fibrosis in the gray and blue, and moderate and extensive fibrosis in the lighter blue and reds. And you see when you go from baseline to year 5, you see a proportion increase in F0 or F1, so minimal fibrosis. So you get regression of fibrosis in these patients with bariatric surgery. So again, a very good therapeutic aspect for patients with MASH, and not necessarily only for MASH, but it's shown benefit in the context of cardiovascular outcomes, sleep apnea, and overall glycemic control. So again, a useful modality considering the patient as a whole again. So in summary, MASLD is a heterogeneous disease and likely we'll see therapies to be the same. There'll be the incretin therapies, which are very centered on the metabolic aspect. We have antifibrotic agents, and there's a lot of optimism. You're looking at the cirrhotic patient, even patients with portal hypertension with some benefits. We're in late stages of development for a number of these assets. We're going to look forward to actually combining them potentially into clinic and clinical trials. The true antifibrotic agents are truly just on the horizon, I think. And again, I think importantly, particularly given the meeting we are at as well, is considering the MASL patient in its entirety with the metabolic aspects. We've talked a lot and you've heard a lot about aspects of mental health and psychology and how many of these modalities need to be used holistically to improve the care and management of these patients.